Thanks to NIC and good afternoon everyone, Chairperson Dr. Gambhir and other people. So let me introduce my team. I do have Dr. Basant, he is Associate Professor in the department working with me. Dr. Patel is a Senior Resident and Dr. Yadav is again a Senior Resident of mine and Dr. Janandar. And on the OCT, I do have a Puneet, and JB is the technician in charge. So can you show the first slide of the patient? No, slide, yes. So this particular case is a 78-year-old hypertensive male who presented with a chronic stable angina class 3 of 6-month duration in April this year. He had a PCI done for the proximal to mid RCA with 3 overlapping giant stent, and also the proximal LCX to OM with 2.75 48 millimeter stent. And this was done in August 2016 at an outside hospital. At that moment of time, 2 months back, the clinical examination was unremarkable. ECG did show the Q wave in inferior leads and right bundle branch block. Echo at present do show the ejection fraction of 40%, regional wall motion abnormality in the RCA, and no mitral regurgitation. This is the echocardiogram, which shows the ejection fraction of around 40%, no mitral regurgitation, though color Doppler is not there. Next. And here is the angiogram, which was done 2 months back. RCA stent is patent. Next. And you can very well appreciate the proximal left circumflex has 100% in-stent restenosis with the CTO. The proximal to mid LAD had a 90% diffuse calcified disease. Next. So this particular LCX lesion, which was the CTO and 100% ISR, diffuse ISR was crossed with the Gaia 2 wire successfully, dilated with 1.5 followed by 2.5 millimeter balloon. Next. And did the OCT, which showed the diffuse proliferative in-stent restenosis, and it's atherofibrotic lesion. You can very well appreciate in the distal LCX, the atheroma and also the homogeneous fibrosis. Next. And this is the proximal LCX having the dimension of say 3.7, and the left main is having a 5.7 millimeter dimension. Next. This is the run across the left circumflex. You can very well appreciate the diffuse in-stent restenosis. And this is all after say 2.5 millimeter balloon dilatation. Next. And then it's a 2.75 10 millimeter cutting balloon, which was used to a further plaque modification of the ISR, followed by a 3.5 38 millimeter synergy stent at the ostium to proximal left circumflex. And distal ISR segment was treated with the 2.75 35 millimeter sirolimus drug-eluting stent. That's the magic touch. We had a TIMI-3 flow across the left circumflex. Next. And there is a good optimization of the stented segment on the post-procedure OCT. Distally again, where we didn't put the stent and had a drug-eluting balloon dilatation, we could achieve the good lumen. Next. So this is the run across the distal unstented segment, the ISR segment, which got dilated with a cutting balloon and followed by a drug-eluting balloon. And here comes the proximal stented segment as well. You can very well appreciate that the ostial LCX, the stent which has been deployed at the ostium of the LCX, is not protruding at all into the left main. So here we are entering into the left main, and this is what? There is a completion. Next view. And here is the LAD orifice, which is widely open. Next. At the same sitting, I did try to cross the LAD lesion with the OCT catheter. It was not successful, and therefore the procedure was postponed, and now he has again been taken on table to do the intervention of LAD after 2 months. So this is all about the case.
So, Rajesh, what we have understood till now is that he has already undergone a PCI stent of RCA and PCI stent of LCX
Yes,
in 2016 and got
2016.
restenosis, and now you have done the instant restenosis using a cutting balloon and then put a magic touch. Looks to be a big vessel, looks to be a great
Yes.
result. And highly calcified LED is now the target vessel that you're going to do. So, what is your strategy for the LED?
Absolutely right.
First of all,
So it's a LED, you can fluoroscope. Yes, please.
yeah, please go ahead. Go ahead.
Okay. So fluoroscope.
What size guide you have
can,
taken, because
see and very
you'll be
well,
fighting with your wire and device in
okay.
visible calcium. So guide is very important, support is important, wire is important, imaging is important. You should use the modern wires and gadgets and device of plug modifications.
Okay, so it's a transfemoral access, it's a 7F sheath, and then we have taken the EBU 7F guide over here. LCS stent can be seen very well, it's a 3.5 millimeter stent proximally, and then it's a LED, you can appreciate the significant fluoroscopic calcification in the proximal to the mid part. Next view. And this is the epicranial, again there is proximal to distal LED which is been calcified. And this is the angiogram. LCS stent is patent both proximally where the stent been put and distally where the drug-eluting balloon was inflated across. And next view. And this is the LED which we are going to treat above.
So there was a lot of
any
negative
comment
remodeling
how to proceed?
in this vessel. What do you think? Is there a lot of remodeling?
Yeah, I think it's a very densely calcified vessel, as you can see from the angiogram itself. And the fact that you couldn't take your OCT catheter inside suggests that there's dense calcification. So you need to find a
Yes.
strategy of balloon dilating and then taking the OCT catheter, or upfront plan rotablation and subsequently take your IVL catheter if required after imaging. That's a strategy I think I would do in this particular patient.
So, what is your plan, Rajesh?
Very nice.
Just quickly spell out your plan in 2 minutes, then we shift to other lab.
So my plan is to go ahead do the rotablation first to have an adequate plaque modification, and to be followed by the OCT examination to demonstrate how significant the calcium is, and thereafter either using the IVL or cutting balloon followed by stenting.
Right. I think so. First thing is you put a rota, get some lumen, and then
Yes.
with whatever device of imaging you're comfortable with, whether OCT or IVUS, that's your choice. If I was there, I would have put a IVUS in this case. And then if rota doesn't work, then obviously you proceed on to the next stage of decalcification with IVL. So with those concluding
Okay.
remarks till this time, I think you carry on with the work of cannulating this LED
Yes,
with
please.
a rota wire or conventional wire exchange to a rota wire. And in the meantime, we move on to our other lab. Huh? Is that right? Okay.
How many of us
Please,
will use
please,
IVL
please, go
from
ahead.
other side? Anybody can comment from the other panelist? Yeah. IVL?
This lesion does not appear to be very critical. So why the OCT catheter could not pass is probably because it is got stuck in one of the spurs, I think. So for a simplicity's sake, maybe you can do a high pressure dilatation and then do an OCT and see, or maybe you can do an IVL also. Sometimes you can avoid a rota.
Okay, so let's proceed. Next. 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 So here there was a discussion going on regarding say imaging. As previously 2 months back we were not able to go ahead with the OCT imaging. We thought let's go ahead and put the rotablation across the lesion, and here is the rotawire exchange. Next view. And this is 1.5 bar Rota Pro. across the proximal to mid LAD. There is mid LAD, there is some resistance. Next view. So this is the point where we had some resistance. Ultimately, we could pass through the rotabor of say 1.5. Next view. And this is the TME3 flow across the LAD. Next view. This is the finishing run across the LAD. Next. And this is what we have achieved after the rotablation. Next view. And this is the OCT catheter still, even after doing the say 1.5 rotaboring, was not able to push across the proximal LAD calcified lesion. Next.
Did you try guide extension?
So it's been dilated with the.
Did you?
No.
Did you try a guide extension to facilitate the OCT catheter going in?
No, we did not. So we actually dilated it with a 2.5 20 millimeter NC balloon. Next. Next. And this is what we had some dissection in the mid part of the LAD. Next. And here we are with the OCT. So can we run the OCT? First run? First run. Can you display the OCT run in the big screen, please? OCT run.
Sir, I want to ask a question, Dr. Gambhir.
OCT
Have
on
you
the
ever
big
seen
screen,
change
please.
of visible calcium after doing rota in your lifetime? Change of visible calcium on the fluoroscopy screen after you do rota. We know that it can change after OCT, but have you ever seen it is changing on your face?
It does not.
Does not.
Because basically what you are trying to ablate is only, you are only trying to produce the cracks and that to intima. And little bit of cracks help you to expand the stent. But if you ask me fluoroscopically, does the calcium intensity or the extent or length changes? No, it doesn't. It's a heavily calcified vessel.
So you can again run it. Yes. The arc of calcification is maximum of say 180 degree. Here is certain dissection, balloon because of the balloon dilatation. Here is the calcium nodule as well. This is the calcium, less than 180 degree arc. Here we come into the left main. Okay, so this is what the OCT finding across the rotablated segment of the LAD. Any comment? What next to be done?
No, you tell us what next should be done, because what is in your plans of action?
Okay, so here there was a concern about whether to go ahead with the IVL therapy or cutting balloon, as the calcification on the OCT is of say 180 degree.
Hello.
I thought let's go ahead for the cutting balloon instead of say IVL therapy. So we did use 2.75
Rajesh,
10
Rajesh,
millimeter
just hold on
Wolverine
here.
cutting balloon.
Rajesh, just hold on here. Let me ask
Yes,
my
please.
fellow colleagues here on the chair.
I'm not
what
sure
is the
if
next strategy? Cutting balloon?
I'm not sure if cutting balloon is a good choice for a nodular calcium.
Okay, so you won't go for a cutting balloon.
I would not go for a cutting
So
balloon.
what is your choice?
If I had access to orbital atherectomy, I would probably use that.
No, what is accessible?
IVL would be a better choice. I think.
I think
So he wants to do IVL. What
There-
about you?
there is a
I think it's enough debulking. Go ahead and stent it.
Okay,
There's a
so
cal-
you want more debulking.
No. It's already debulked enough. So you have to choose your best stent in the
He
world.
has shown a nodule there.
Rajesh.
Oh no, nodule is not that big. I mean,
No, nodule is quite big. Rajesh, do you
Yes,
think
please.
this nodule is going to go away with just stent?
Rajesh, there's a calcified
I
nodule.
think so.
Okay. So you think that you possibly can go again with a...
We have already rotablated.
No, but do you think this is a
I-
after rotablation nodule is still there?
There's a calcific nodule for which
See, the
IVL is an
option
off-label
is
use.
If you don't modify it, you're going to have an unexpanded stent at that portion.
You may have a unexpanded but unevenly expanded.
we can have IVL after unexpanded.
IVL that way,
Okay, what
that
about
way an
you?
off-label use.
Pardon? I think there's a problem of a calcific nodule. We
Okay.
don't have a standard thing to address it, possibly. Off-label IVL can help.
Okay.
For a calcific nodule, IVL off-label use is there.
So,
Rota possibly.
there is
Rota
a
and-
difference of opinion. There is a difference of opinion here. Some people want to just stent it. Some people want to use IVL. But if I have to do, I will upsize the burr. I will straight away go with a 2 millimeter burr. It's a very large size artery, and do just a little bit more of debulking and cut away this nodule, and then see whether he needs any cutting balloon or whether then we can go with the stent.
So there are two types of calcific nodule, as Renu Virmani has described in 2000.
There are 6 types of nodules.
But on OCT, the thick cap or thin cap, that's it. This got a very thin cap calcific nodule. Now, if you have stent under expansion, still you can use IVL because there's only energy which can work beyond the stent strut. So you can go for another cutting balloon or OPN balloon. OPN balloon will also work here in calcific nodule.
Okay, let's see what is your plans and what have you done. Okay, Rajesh, go ahead.
Okay, so following the OCT examination, we could to a great extent modify the calcified plaque. Next view, please. And this is what we had proximally. Yes, the proximal part of the LAD is still somewhat not so dilatable compared to what the mid and distal. And we do have the mid LAD where the dissection is there. Next view. This is again a cutting balloon, 2.75. We went up to say 20 atmosphere at this particular point to have an adequate dilatation.
Okay.
Next.
What is the size of your artery on OCT? Media to media?
So artery size is 3 millimeter distally and 3.5 proximally.
Okay, so
At this ectatic segment, at this dissected segment in the mid part, it's a 3.5.
do you have a
And
3.5
distally,
cutting
it's a 3
balloon?
millimeter.
Do you have a 3.5 cutting balloon with you?
We do have up to say maximum 3. We have already used 2.75 at this point of time.
Okay, go ahead.
Okay, next.
Next.
So this is what? Next. And this particular portion of the proximal LAD is somewhat got dilated following the cutting balloon. There is a dissection, a significant dissection in the mid part of the LAD. Next. And here we went ahead, we say 348 synergy stent. Next. 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 And it's a 3.524 synergy in the proximal part. Next. 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 There is some dissection in the proximal LAD as well. This is 3.5 stent across the ostium to the proximal LAD. Next. It's, if you see, it's a well expanded at this particular point. Next. Next. And this is what we have achieved. Thereafter, we have done the OCT across. So can you run the OCT? OCT, big screen, please. So you can very well appreciate we could dilate the proximal LAD to a certain extent with the stent. There seems to be angiographically distal LAD and also the proximal LAD, some under expansion, which we can very well have a look on the OCT, what it is. So this is the OCT run. Can you restart the OCT run from the beginning?
No,
Okay.
you just show us the proximal part of
Distally,
the
do we have any dissection? No dissection distally.
Distally is well expanded, well opposed stent.
Okay, here is the point. How much is the area at this point, Puneet? So this particular point, we do have an area of how much? 4.9 millimeters square. Okay. Go proximally.
Can you go back to 35 something?
35, 35, Punit. Just complete the run and then we can come back to
Yeah, please,
at
please
the level of
continue.
35.
No, show us 40,
Here we are.
40, 50.
Just run it. So let me give 3 millimeter NC balloon. So Puneet, can you comment about distally how much is the area, how much under expansion is? Distal part where we have put the 3 millimeter stent.
Expansion you are showing in reference to the distal vessel. If you show the expansion in comparison to the
Yes.
left main, then it is under expanded. But in the software, they're actually taking the distal vessel diameter. That's why 100 plus. This is too much.
No, it's fine, but angiographically you can very well appreciate there is under expansion in the proximal and distal segment, which we are going to dilate it with the NC balloon.
If you do not have any problem with the
what
IVL,
the plan is
you can
to have
open up
now-
one IVL now, 3.5 or 4 millimeter IVL here. You can try your IVL.
No, do you feel like now using the IVL, when we do have achieved a good area, and let me try to open it up with the NC balloon instead of going for the IVL. In case we are able to achieve the good area with the NC balloon, I think we are okay to go at 4.
I
Sir,
think
any
NC
chance of
balloon and
perforation here? No.
Pardon?
NC
Perforation,
balloon.
NC 4 millimeter balloon or 3.75.
No, I don't expect any perforation, but first thing is my comment is I still feel the stent is very much
12,
under expanded in the
15.
proximal part. Now, see the
18,
proximal part has to be bigger.
18.
The left main is 5. The distal vessel is almost 4, 3.84. And proximal vessel is still shorter, smaller looking at least an angio and also an OCT, longitudinal view. So you need to expand the proximal part, that's one.
Okay.
Now, how you would get this, you have to decide whether you go for a NC balloon, you go for a OPN balloon.
18,
But it
1.
certainly needs much more expansion than angiographically. Well, it is a okay result, but you can't call it a still you have achieved the ideal result. So you have to plan out strategies beyond this now.
I agree with Professor Gambhir that the proximal portion is definitely under expanded. But having put a stent there now, to over expand it with a non-compliant balloon or a OPN balloon, there's a risk of perforation. I think to have it be safer to
18.
use an IVL balloon at this point of time. Only when you have a lot of calcium and a nodular calcium there.
Okay, I think Dr. Rajesh, since we have to go to Germany, let's move around in the Germany in a good
Yes,
weather.
please.
So you please carry on with
So-
your work fully. Over to Germany.
Fine, fine. So, fine, okay. Okay, so
The blood pressure is going down.
go back. Yes. Back, 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 back. So we have dilated the LAD distal segment with the 3 millimeter NC balloon and proximally 3.5. Next view. Next view. Next view. So this is 3.5. Next. And this is what we have achieved. There is still, though the distally we have achieved a good lumen, no angiographically under expansion, but then the proximal part of the LAD is still having the under expansion despite 3.5 millimeter NC balloon across this particular segment being inflated at 20 atmosphere. We did the OCT run again to look for how much is the improvement. Can you run the OCT?
Quickly run through the OCT and then we say goodbye to you.
OCT. OCT display on the big screen, please. So this is the OCT. We still have some under expansion. Can you, here is the portion where we do have the area of say 4.89 millimeter square despite having a NC balloon dilatation. Run proximally. So at this particular point, when we are not successful with the NC balloon, we have taken a 3.5 IVL balloon. Next view, please. No. Okay, fine. So here we are, inflate. So this we are giving the therapy with the 3.5 IVL across the proximal underexpanded segment. This is the 5th cycle which we are giving. And hopefully we will be able to now dilate it better. So 5 cycles we have given at this particular point. Let me dilate the distal portion as well. Six. Negative. So this particular segment is the one, I think this again required inflation at 6 atmosphere. Meanwhile, patient is having some fall in the blood pressure at the time of the inflation, for which a minimal inotropic support has been started. 4 and 6. So this is the particular point. This must be. So how much is left? 2 cycles is left.
How many atmosphere? 4 and 6. This is IVL.
It's a 4 and then 6. 8. Negative. Negative. 1 cycle is left. So go 4 and 6. So
Rajesh,
this is
you
the
also
last
have
cycle across the LAD. Negative. Okay, so now let me post dilate it and then do the OCT.
Rajesh,
Let's
I
have
think
a
you
look on the
also have to
angiographic,
remember
how much
that
improvement.
there is a little bit of ectasia in the mid segment of the LAD. So maybe I think if you try to achieve to that area, you may not be able to achieve.
The last cycle should have been at 10
See,
atmosphere.
mainly we
You have 4-6 cycle, 6 atmosphere, but usually we use the highest pressure because that is the end of your life of the IVL. So I would have gone into 8 to 10 atmosphere and finished it.
I think this is for mostly for the say plaque liquefaction, and now with the appropriate size NC balloon, I can very well dilate this segment. So let me go ahead with the 3.5 followed by say 3.75 proximally. So let me give the 3.5 to be followed by 3.75 balloon at the proximal segment to have an appropriate dilatation, followed by a repeat OCT. Distally, we have achieved the good result across after having a 3 followed by 3.5 millimeter NC balloon dilatation, and this particular segment we have successfully done the
Rajesh, I
therapy.
think since we are
3.5
running
NC
behind time, we have finished our 1 hour of live
sir.
transmission. So I think you continue with the work. Maybe you might have to go to 3.75 balloon.
Fine.
But my gut feeling is this is not going to dilate further anymore. No. So I think, well,
Let's
you
see
may
how
try
much
your
improvement
efforts,
is
but see to it that the patient remains safe, and whatever you could get, please show us tomorrow. Okay? Thank you very much.
Do you
But
still
wonderfully
feel like
wonderful demonstration of rota, and then cutting balloon and followed by IVL. So after trip
thank
C,
you.
you may
Thank you very
possibly go to a rota once again. Okay, I think we can cut off the live transmission and go on to cases. No, I'll show you a case tomorrow. Okay, Rajesh, thank you very much. A word of applause for all
Okay,
that
thank
good
you very
work,
much.
good work done by you.
14, 18. Sir. Negative. Okay, thanks the NIC for the invitation.